And I'm just going to talk about some of the things that I've been doing with people. Primarily Jake is my supervisor, looking at how we manage trauma patients at QMC. So coming up, we're going to talk about what we got up to in 2023 in terms of numbers, have a look at some of the landmark or big hitting clinical trials that came out over the year, a little update about TXA, a recap and sort of pointers of how we manage our trauma laparostomy patients and how the future of trauma anaesthesia is going to look like, especially for our code red patients. So 2023 in numbers, it's been a busy year to say, and to have a look at how we're doing in terms of busyness or acuity. It's always good to look at TARN data, and for anybody who is third on call or anybody who's lead clinician, it's not unsurprising to know that according to TARN, we were the busiest trauma centre in the country by the end of 2023, and it certainly feels like it some days. So yeah, so whenever you feel exhausted at the end of your shift and look at how many steps you've clocked, the reason why is because we're the busiest trauma centre in the country. So what does that look like? So in total, we just had over 1,800 trauma calls this year, just shy of 150 reds, the majority being amber calls. Green ones, team anaesthesia don't attend to, but we may get involved in at a later point, and 100 paediatric trauma calls. So that averages out on a 24-hour period that we go to about 5 trauma calls a day. Some days we don't have any, some days we have multiple. The shock index or the utilization of the red, amber, green by ED works quite well because we've only had 4 amber trauma calls that were reactivated to red over that 2023 period. And of the trauma calls that we attend, the vast majority of all the trauma calls that we get involved in are still RTC or fall related, vehicle related or occupational related. However, out of the reds and ambers that we have seen this year, there has been a spike in the number of shootings and the number of stabbings that we've seen come through our doors. So a busy year all in all. So in terms of blood, because I find this quite interesting, one of my areas of interest is how many transfusions we've done, okay? And this has come from the transfusion practitioner team who've kindly given me the data. And these are the units transfused that we've given from the code red or blood being requested in ED and up until the either go to ICU or theatre. This does not include the patient's subsequent transfusions for their later operations, etc. So we are keeping roughly to the 1-to-1 ratio, which we should be instigating for all our trauma patients as a form of fluid resuscitation, hypovolemic or shock patient. And then we are utilising cryo and platelets sparingly, as we should do, because of the low stock rates of a lot of these blood components and how scarce they are. Interestingly, out of the data that I've crunched through, one trauma patient this year was up to pack 10 of the trauma packs received, and that from admission to ED to going to ICU, they had transfused 95 units of blood, which is pretty impressive. And just to recap what we have in each of those trauma packs, pack 1 will have 4 red and 4 FFP, and pack 2 will have 6 red, 4 FFP, a pool of cryo and a pool of platelets. And just remember, whenever you think the patient needs cryo, we need to have that discussion as the lead anaesthetist or whoever's available to have that discussion with the blood bank, is we need to have evidence for why we need that cryo, because they will ask us, they will not initiate it automatically beyond that point. And beyond pack 3, you will be getting a call from a transfusion team of saying what's going on, what's the clinical details. You may even get a hematologist ask you those questions and why you require those blood products. So it's vital that we probably do a TEG sooner rather than later with a lot of these patients. And this is a QR code to Jim's excellent talk on TEG interpretation. One thing I probably think we need to point out is that sometimes the cartridges are hard to get hands on, or they're low stock supply, or there's not that many people free to run it. Is that if there is ongoing bleeding, we should just carry on with our trauma resuscitation of the 1-to-1 and using whatever blood products we have available. Because if we haven't stopped the bleeding, or they haven't got a clamp on something, the nuances of TEG aren't going to be as helpful until they have that clamp on or have some sort of hemorrhage control. Then the fine-tuning of TEG, given specific blood components and blood products, comes into a league of its own at that point. So yes, it's really important to get that TEG and that long transfer time coagulopathic patient who's been outside for a considerable period of time at the side of the road or entrapped in something. But one of those patients that have had an injury or an RTC, quick extraction time, a quick transfer to hospital. In the ideal world, the TEG won't be as useful then as it will be in the previous patient. So getting that clamp on, getting that control, and then fine-tuning with the TEG is really important. So if we look at overall 2023, what we got up to, over 1,800 trauma calls, over 1,000 units of blood products transfused, is a lot of work. But something that we should be really proud of is that of all these patients that we were involved with in the trauma calls and all these patients that had received a transfusion, so I thought it was quite surprising, but we only had 20 deaths of these patients in that 30-day period, which is extraordinary, and something that we should all be very, very proud of, because it's indicating that what we're doing is going in the right direction. So that's the numbers. Let's take a look at the clinical trials and the headline clinical trials of this year in relation to trauma anaesthesia. Slightly biased, but Critical Care Reviews, and this is a link to their website, do daily reviews of research articles and trials, and it's also a fantastic conference because it's held in Belfast. So if you want some good CPD, aim for Critical Care Reviews in the summer of 2024. But the main headline grabbing clinical trials of 2023 were PATCH, Cryostat, and UK Reboa trial. And if we just mention PATCH briefly, PATCH was looking at TXA, the 1 gram infusion, with the 1 gram bolus, forgive me, and then the 1 gram infusion over 8 hours, and comparing that with placebo effect. And this was done in Australasia and with the ANZAC groups, looking at pre-hospital patients who had quite a strict criteria, shall I say, for giving TXA. So a lower blood pressure, a high heart rate, and reduced GCS, and probably not as easy to give it as we do in the UK. And they showed that there was that the quality of life was no different. So i.e. the level of their traumatic brain injury or their length of stay in hospital, etc., was not different between the groups. So the group that had placebo and the group that had TXA. And it didn't reduce the amount of blood products that they had to give. And this was sort of presented as, should we be given TXA after all? Question to the critical care group at the Critical Care Reviews. But the general consensus was that actually, because they were so specific and sort of limited inclusion criteria in their trial, we don't really know what the greater overall picture was that was indicated in CRASH 2 and CRASH 3. So there will be a lot more analysis of this trial, especially the subgroup analysis, as time goes on. And I'll mention something a little bit about the interpretation of this result when I mention TXA and NICE's conclusion of this trial in a wee minute. Cryostat 2, which looked at the given high dose cryo to hemorrhage in trauma patients, and looking at the reduce their hospital stay, to improve outcomes, to reduce the number of transfusions that came through. I honestly thought this was going to be the pièce de resistance. This was going to be the pinnacle of trauma care, and we all thought that given a whole load more fibrin early on in the process was going to improve outcomes and improve hemorrhage control, etc. However, the results of the trial didn't support empiric cryotherapy in these patients, and one of the things that the authors and the limitations and people who've done the subsequent analysis of this paper was that getting the right timing off it. So they had an inclusion criteria of giving the cryo within 90 minutes of injury insult. And a lot of the authors and a lot of the very clever people who've analysed these papers thereafter have felt that maybe that was too long. It should have been a tighter period of time. So we should have been given cryo sooner in the trauma process in the Goldilocks zone, and that may have had a different impact. But again, further future subgroup analysis and that will probably come out later on this year, will really shine light on that. But one thing that it has pointed out, both the TXA, the patch trial, and the cryostat trial, is the utilisation of TEG or ROTEM in these major trauma patients, and given not a ready, steady cook approach to trauma care, but a tailored Michelin star guided menu specific to that patient of what they specifically need and require. The last but not least big trial and sort of headline grabbing research that came out in 2023 was looking at the UK REBOA trial. And the REBOA trial, just to recap, or what the role of REBOA was inserting a catheter with a balloon in it at different points within the aorta to occlude the aorta and stop bleeding there after that point. And the UK REBOA trial had a negative outcome, that so much so that they sort of stopped recruiting early on within it. And they felt that multiple things were occurring within the REBOA trial, that it was delaying definitive treatment for some patients, potentially, that there was lots of injury to blood vessels whilst trying to insert these catheters. And they had a very negative outcome that they stopped doing it within the trial period. However, this is take it with a pinch of salt. This negative outcome of the REBOA trial, interesting trial, but these were all inserted in the ED. These weren't REBOA devices inserted in the pre-hospital environment where there may be a significant transit time to definitive care. So yeah, I don't think is REBOA completely dead in the water in terms of trauma management in the UK. At the minute, there will be limited people uptaking it, but I still do think it has a role in the in trauma patients, but we just need to define that very clearly and carefully. And the people who are inserting the REBOA devices should be sort of more clear, more defined, and more skilled at what they're doing it, because it's something that it takes quite a skill to do in a timely fashion. So a little bit about the update on TXA that we've worked on. Some of you may have seen the posters in the coffee room or in the ED. So what we're saying is that although Patch had come out and said, we don't think it makes much difference in these trauma patients, and contradicted all the massive crash trials, crash 1, 2, and 3. The NICE had looked at all the evidence post-Patch and made these very clear additions and guidance to it. And the big thing that we need to be aware of is that, number one, is that we can give a 2-gram bolus if they are presenting to ED and haven't had any pre-hospital TXA, when we can give that within 2 hours of injury. So therefore, we reduce the need for giving the 1-gram TXA bolus and the TXA infusion, the latter of which we were terrible at in the UK, have given a TXA infusion after the first initial bolus. And that we should also be thinking about giving TXA to people who have a mechanism of injury where they have a GCS of 12 or less. And that has come from the Karen Lecky's group in who works with Tarn, has looked into all the data sets in all of the trials on the crash 1, 2, and 3, including the Patch trial, and more recent research looking at TXA and traumatic brain injury. And the NICE committee felt that the risk benefit, the benefit of giving TXA early was far better and far greater than not giving it at all, and particularly the traumatic brain injury group. So the headline from this is that if they've had a gram pre-hospitally, we give another gram in ED whilst we're doing the primary survey or going to scan. If they haven't had anything at all, we give a 2-gram bolus. And Karim Brohi talks about this quite a lot. Lysis, Karim Brohi, for anybody who doesn't know, is the sort of ROTEM tag master of trauma coagulopathy, and we are seeing less and less lysis on our VEGs than we are at any other time before, because we've got such an uptake in administration TXA pre-hospitally and in the ED. So again, it is showing a benefit in that regard in the UK trauma population. Little bit about trauma laparostomies. We do a lot of trauma laparostomies in Nottingham compared to other parts of the country that I've worked in. We wanted so this is a poster that we've created, sort of an aid memoir that we'll be putting up over the next couple of weeks in the emergency theatres and trauma theatres, and it's something I'll send out to everybody so they can have it on their phone as well. And it's just an aid memoir to remind you of things that we should be aiming for during our trauma laparotomies. Again, given that 2-gram bolus of TXA, aiming for our goal-directed fluid resuscitations and trauma-related resuscitation if given our 1-to-1 ratio. Warming our patients, so whether that be getting an underbody bear hugger on the operating table and then putting the patient on top of it, which would be beneficial because most of these patients are in a crucifix position and totally exposed. Having sit reps and conversations with the surgeons at all points of making it damage control if the patient is unstable, if the operation's taken over 90 minutes, and doing that as per the trauma anaesthetic chart, which is found in Resus, that we have a pause point every 30 minutes to make that discussion. Doing regular gases to check their metabolic state. So if it lactate's greater than 5, should we just put clamps on things or tie things off and come back another day? And keeping an eye on that calcium and potassium as we go throughout it. And if the potassium is starting to increase or normal and we are given massive transfusions, we should really just be starting an insulin infusion to avoid that hyperkalemia that may not happen in theatre but will sneak up on ICU in a period of time afterwards. As ever, avoiding vasoconstrictors until we know exactly what's going on. So continue with fluid resuscitation with our blood products until we have a scan or we are intraoperative and we can see the bleeding point or the lack of bleeding point. And therefore, then we can use some purple stuff to increase the mean arterial pressure, specifically if we consider a spinal cord injury or traumatic brain injury, only until we can see a point where there's no bleeding point. Regularly testing our clotting, so we should be doing a TEG after every major trauma pack, ideally in an ideal world, but it takes a long time to take the blood, get somebody to load the cartridge and run it, and using the TEG systems to see the change on it on the computer screens, and also taking lab samples as well concurrently, just to have more evidence to have discussions with hematologists about why we need to continue with certain blood products, for instance. And the role of imaging, just knowing that we have to have an honest conversation with the surgeons and the trauma team as a whole, whether or not this patient needs further imaging to see what's going on, whether that be an IR-based imaging or just plain CT. And as forever with anything within major hemorrhage, don't forget that calcium and be given calcium chloride or calcium gluconate. I know there's some supply issues at the minute, but we with the calcium chloride, but if we can, it's a more concentrated, smaller volume to give. If we can give it, try and give calcium chloride at all costs if we can possibly do it. And finally, just a little bit about our code reds and what we're doing about them in the future of code red trauma. At the minute, as every code red or anything that's mildly interesting that happens in resus, there's a lot of people and a lot of people want to get involved, which is absolutely fantastic to have as many bodies, but sometimes we feel like a lot of people are watching us and there's not many people doing the actual resuscitation or work. regards of it. But I think one thing we're trying to work with Tom, who's the Band 7 in acutes and from Team Anaesthesia, is that all co-reds, and it happens by proxy anyway at the minute, but we will sort of make it onto the trauma anaesthesia guide, is that 2 senior anaesthetists go to each co-red trauma along with 2 senior ODPs. And we sort of divide roles, which happen naturally anyway, but we have more defined roles. So one anaesthetist is in charge of access, inserting the swan for rapid transfusion, or a couple of big cannulas, whatever is more feasible, and insertion of an arterial line. And this is a new thing because a lot of our pre-hospital patients will be coming in with normally femoral or mostly femoral or brachial arterial access, which we can get beat-to-beat analysis on. And not the only benefit of that is that we can also take rapid samples for grip and screen, blood gas results, and TEG. But we know time and time again how unreliable non-invasive blood pressure is. Not that I'm saying that we, Team Anaesthesia, should get fixated on getting arterial lines in and swans in before doing other things like getting the scan or getting the theatre. But if we have 2 sets of anaesthetists and ODPs to do that, that one task should be derived to one anaesthetist and one ODP to get access sorted and an arterial line in as soon as we can, because we know we've got accurate beat-to-beat analysis, and it just makes the whole process a lot smoother, especially with the time it takes and scan. It helps with decision making, and we can see sudden rapid changes a lot quicker than we would anywhere else. And then the other set of Team Anaesthesia and ODP would manage their way, getting things prepped, giving sedation for that chest drain or splinting of the limb or whatever that case may be, until whatever point it is safe, if we need to get the patient off to sleep. And encouraging Team ED to be the people, or the trauma team leaders, allocating roles to people who will man the Belmont and check blood and continue with that. Because at the minute, and it's just a work in progress, I suppose, it's just defaulted to a lot to Team Anaesthesia to manage the Belmont in terms of the ODP, checking blood and giving blood, where actually we could give that role to Team ED, and we could focus on A, B, and C, or C, A, B, C in most cases. So that's hopefully what the future looks like. And then obviously there always is that decision, do we go for that 10-15 minute scan, which ultimately it does take between transfer or not, or do we go to theatre? And that will be a team discussion and a team decision at that point, but it will be a lot more clear and a lot more evidential if we have able to get good access, transfuse these patients, and also monitor them beat by beat, which will give us a lot more clear and more confident basis to armor our questions or answer those questions depending on what we're seeing at the end of the bed. So whether it be going to CT or taking them upstairs for that trauma laparostomy or whatever the case may be. So that's a whistle-stop tour of what I've been doing over the last 12 months, and what will probably continue over the next whenever the next trauma fellow comes along.